are going to be lower, but more of our patients are going to live on this type of a protocol. The other thing that's very, very important to stress, especially in an obese population, is that these tidal volumes are based on ideal body weight or predicted body weight, not actual body weight. So if you have a person who's 6 foot tall and 350 pounds, that doesn't mean that they're going to get, 6 cc's per kilogram at 350 pounds, rather 6 cc's per kilo of their predicted body weight. And attached to this order set is the predicted body weight for patients, for males and females of very broad height.
Okay. In terms of when you're putting someone on this ARDS protocol, let's say, when are you deciding to use this? You had them. I'm guessing perhaps that some of these patients come in, you actually have them on the routine mechanical ventilator order set. When does the pulmonary critical care doc say, okay, we need to really move to this ARDS protocol with much lower pressures and things like that?
The move is typically made anytime the diagnosis of ARDS is made. And so if somebody started off with an aspiration, they have a unilateral infiltrate, and they're in the intensive care unit, and then they move, indicators that somebody's moving toward ARDS would be the following: worsening oxygenation. The definition of ARDS from an oxygenation standpoint would be a PF ratio of less than 200. PF ratio is the PaO2, the arterial PO2 on the ABG, divided by the FiO2. For instance, if somebody has a PO2 of 100 while on 50%, which would be 0.5, that would be a PF ratio of 200. So that's one of the first indicators that ARDS may be coming on, as worsening oxygenation manifest by that lowering PF ratio. The next is a 5-lobe alveolar infiltrate. So something that would go against ARDS would be a unilateral, right lower lobe infiltrate from community-acquired pneumonia. Somebody could easily have a PF ratio of less than 200, but that could be explained by their pneumonia and not by ARDS. So ARDS, by definition, is a diffuse alveolar infiltrate involving all of the lungs. And then the final key to that is more than one thing can cause diffuse alveolar infiltrate in all of the lungs, and one of the huge contributors to that could be increased left atrial pressure, meaning somebody's in either systolic or diastolic heart failure. So before the diagnosis of ARDS is made, your estimate of left atrial pressure, whether that's by echocardiogram, checking a serum BNP, physical exam, right heart catheterization, whatever the case is, you got to make sure that you're not calling acute heart failure ARDS. But once those criteria are met, number 1, PF ratio less than 200, number 2, 5-lobe alveolar infiltrate, number 3, a normal left atrial pressure, then the diagnosis of ARDS is made, and we should be transitioning to lower tidal volumes.
And it also moves us to this box over here, which is where we're considering ECMO consult. And I do think it's really valuable. The St. Louis Health System has ECMO as an opportunity for our patients. I know that you've probably seen some cases where an ARDS patient went to ECMO and actually eventually lived to tell about it. And perhaps you could tell us about that. And take us through, this issue about when you decide you're going to call. Michelle Haynes, I think, is the medical director for ECMO, and when you're going to give Michelle a call. The number's here on the order set to try to be thinking about ECMO. And this would be for any of our hospitals in the health system. If we've got a patient on the ventilator, obviously the EICU doctor may be helping to make that call, but if any physician in our health system that's got a patient on the ventilator can be looking at their patient and deciding, should we make that call for ECMO?
ECMO is an invaluable tool, and we have met with a lot of success in our ECMO patients. The times when the phone is ringing from my standpoint to call Dr. Haynes would be in a patient with, that we are seeing very rapid deterioration in oxygenation and failing to be able to keep up with it with conventional ventilation. Most recently, there was a 40-year-old plus or minus female who was admitted to the hospital after 3 days of worsening dyspnea. She was then followed a course of requiring 2 liters, then 4 liters, and then 50%, and 100% non-rebreather. Then we find her on the ventilator within about 3 days of her hospitalization, and you could just see a rapidly progressing disease process moving forward in her. In her case, it was acute interstitial pneumonia. She was put on the ventilator, and pretty refractory to elevated levels of PEEP. You know, she was on 20, 22 of PEEP, 100% FiO2, and I felt at that point that, you know, in order to get oxygen into this lady's blood, we were going to have to do something, you know, more drastic. And this was very early on in the course. So important things to consider during for ECMO is, number one, you got to have some hope that the patient's going to survive. You know, you don't want to take somebody with a dismal prognosis and then go forth with, you know, running through ECMO and everything like that, because if somebody has no chance of survival from their disease process, then that exercise should not be undertaken. The next thing is the patient should not be on the ventilator for more than 7 days. The infection risk, and that's one of the exclusion criteria, as a matter of fact, for going on to ECMO. And the third thing, I think that some of it's just, you know, how sick the patient is and how fast they're getting there. It just seemed like the freight train was going in one direction on this gal and needed to be, you know, changed. And early steroids in this case were not, in my opinion, going to do it. Antibiotics up to this point in the patient's hospital stay had not done it, and there was zero indication that there was a cardiac component to this. So this was a disease process that clearly was going to have to run its course. And the question was then, were we going to do an oscillator? Were we going to do ECMO? Were we going to do conventional ventilation? So we consulted the ECMO team, and initially oscillatory ventilation was tried in the CVICU, but similar results were experienced, so the patient was transferred to ECMO the next day. The take home on this would be a rapidly progressive hypoxemic illness. A lot of times that could be ARDS, acute interstitial pneumonia, and then when the H1N1 epidemic was around, that was a huge benefit of having ECMO, because this would take young, otherwise virile patients and you know, giving them a bridge to allow the disease process to run its course and then get the patient back to normal.
ECMO meaning extracorporeal membrane oxygenation. So,
correct.
And can you tell us what severe air leak syndrome would be in a situation? That was another criteria that they mentioned on here, and I wasn't exactly certain what that would be applied to.
Severe air leak syndromes would be where a patient has barotrauma. Okay. And barotrauma or volutrauma indicating a bronchopleural fistula that is not closing.
Greg, we really appreciate you taking time for us today and taking time to take us through these order sets. They're online, they're available to the clinicians to use. Please take some time to review these, and thank you for your time.